Good day. I am Dr. Teke Apalata. I am a specialist in clinical microbiology. And today we are going to discuss sexually transmitted infections. And during this first part of sexually transmitted infection, we will mainly discuss an overview about sexually transmitted infections. So let me just share my screen with you before that we start. So I said that we are going to discuss sexually transmitted infection. So let's start with with the understanding of the transmission of STIs. And the transmission of sexually transmitted infection was actually established by a British surgeon in the name of John Hunter in the 18th century. So there are a lot of controversial information regarding the way John Hunter actually came about establishing the route of transmission of STIs. It is said that John Hunter inoculated himself with gonorrhea pus from a patient. So he took the pus from a patient who was found to have gonorrhea. Then he inoculated, he took the pus and he rubbed his private part with that pus. Then it happened that this patient had both gonorrhea infection and syphilis. So John Hunter ended up with the two types of STIs at the same time. But then the controversial information came from other sources. There are other claims actually about this situation. It is said that John Hunter actually did not inoculate, inoculated the pus. He did not rub it with himself, but he actually inoculated it into another man, not himself. So it's the other man who actually developed the infection. So of course, if it happened that he did it to another person, then that becomes a really unethical issue. But despite all those controversies, John Hunter managed to establish the route of transmission of STIs. And he then summarized that by saying that STIs spread by direct intimate contact through mucosa or damaged skin. So this is the current understanding that we have about sexually transmitted infections came from the work done by John Hunter. Now, there are numerous etiological agents causing sexually transmitted infections, and most of them are either bacteria or viruses. We have bacteria like Neisseria gonorrhea, Chlamydia trachomatis, Treponema pallidum, Haemophilus ducreyi, and Calimacobacterium granulomatis. And we have viruses like HIV, herpes simplex virus, human papilloma virus, and hepatitis B virus. And then we have the parasite like Trichomonas vaginalis. That is one of the commonest causes of vaginitis in women. Then we have other microorganisms that are misclassified as the causes of STIs, but they are not sexually transmitted infection, and they are known to cause vaginal discharge in women. One, it's a condition called bacterial vaginosis. Bacterial vaginosis, it's an infection of the vaginal mucosa, that is a result of mixed anaerobic bacteria, a combination of many bacteria, including Gardnerella, ureaplasma, mycoplasma, and so on. They come together, all these, they come together to cause a condition that we call bacterial vaginosis. And we have also another commonest condition called Candida albicans or Candida vaginitis. It causes a condition in women that we call vaginitis, due to Candida albicans. It's also not a sexually transmitted infection. So those two conditions, bacterial vaginosis and Candida vaginitis, occur because of the change of the pH in the vagina, not because of a sexually transmitted infection. So why do we have a change of the pH in the vagina? It's just due to numerous practices from different women according to different products they use to clean themselves, to clean their private parts, maybe the different soap that they use, the different material, underwear material that they use. Some are with cotton or nylons, or it increase the temperature, so modify the pH. And as a result, if the pH drops, the normal vaginal pH is it's 4.2. It's 4.2. So now, if you have a drop in the pH, Candida albicans proliferate. Okay. Then, if you have an increase in the pH above 4.5, from 4.5 and above, you have bacterial vaginosis that develop, take over, and create a condition that we call bacterial vaginosis. So the normal pH is maintained by a microorganism, so that we call lactobacilla. So lactobacilla maintain the pH of 4.2 in average in women. So anything that changes the pH can create that dysregulations, unbalance, and it's either if the pH drop, Candida albicans takes over, or if the pH increases, we have a condition called bacterial vaginosis. So those are not sexually transmitted infection. I have received numerous patients who come and they are partners complaining because they don't know where their woman contracted this infection, but it's not a STI, it's not a sexually transmitted infection. We will discuss these conditions, but we will mainly discuss the true sexually transmitted infections and the way they happen. Then, what are the sites of infections of STIs? The site of infection of STIs, of sexually transmitted infection, is function of sexual preference, okay, and practice. So it's because it depends on your sexual behavior. So there are people who are heterosexual, those who are homosexual, and people have different sexual practices. So sometimes we look at STIs at wrong places, because everything is influenced. You need to understand people's sexual behavior, sexual preferences, and sexual practices. Okay, but in many cases, you can find the infection in the genital area. Like in this case here, you can see this patient with an ulcerative lesions, a penile lesions. And you can find here in a woman, you can also find that there is an ulcerative lesion there, okay? So then if you have a woman like this who is infected, there is a risk that this lady gives birth to a child who will also, through the process of birth, passing through the vaginal canal, then this child will also contract a sexually transmitted infection. So we can have children, for example, the mother was having herpes, then the child is born with congenital blisters, congenital herpes, or some children can even develop more complicated condition like encephalitis, okay? So people who do oral sex, for example, will develop oropharyngeal infections. I receive patients with pharyngitis, for example, and you treat them like a streptococcal pharyngitis, and you give them penicillin, though they don't recover. You try macrolide, they don't recover. Then when you try to understand their sexual practices, they often practice oral sex. And it's actually a gonorrhea infection, oropharyngeal infections. Then you put them on third generation cephalosporin, you see they recover. And the other people, they do anal sex, so they can have, you can see here, it's actually a human papilloma virus infections in the anal area. So they develop anal infections. So when you are trying to deal with a condition like sexually transmitted infection, you need to understand people's sexual preference. Now, in terms of clinical presentations, majority of sexually transmitted infections will show signs on the genital area, but some will not, okay? So those that show sign on genital area, like the classic sexually transmitted infection, like that we call actually sexually transmitted disease because you have signs on the genital area. And the others, like secondary syphilis, for example, or HIV, you can find signs elsewhere. You will see someone with secondary syphilis who will actually develop rash. Or you will see HPV infection maybe on your fingers or maybe on your toes or anywhere else, or you can see other patients who develop disseminated gonococcal infection, they will actually develop arthritis. So not all of them are found, not all signs are found on the genital area. That's why we don't prefer to use the terminology sexually transmitted disease, but we speak about sexually transmitted infections. So the infection might be clinical, the infection might be clinical, it might be subclinical, it might be localized, or it might be disseminated, you know, resulting in complications. But there are three major classifications when it comes to the clinical presentation. So you have STIs that produce what we call genital discharges. Whether a male patient or female patient will come to you because they see a genital discharge that we also call a drop, okay, especially in males. In women, it's also called mainly discharge. There are those that cause ulcerative lesions. You see a wound, a cut, you know, a blisters. Okay, that's another group. And another group that cause then other type of lesions elsewhere outside the genital area. Okay, so those are the three groups. Now let's look at the first group. We have STDs that produce genital discharges. Now, look at this in a male patient. You can see pus coming outside through the urethra, okay, that we call drop. So this condition here, so this is a true pus. But sometimes you can just have something like this. It's a very clear fluid coming out, you know. So we need to be very careful, especially when we are dealing with a young man, very young men. Sometimes they can just have dysuria. You know, they can have dysuria. Let's note, if you receive a young man who complain of painful urination, in many cases, even if there is no discharge, in many cases, you have to suspect a sexually transmitted infection because it's very rare for men to develop a urinary tract infection. It's very rare, but in many cases, it might be a sexually transmitted infection. So sometimes you can see the classic presentation here of a pus, or you can just see a very clear fluid, or you don't see any discharge coming, but it's just painful urination. You have to suspect, so you can check for urine, you can do a urine analysis, of course, but you also need to check for sexually transmitted infection to try to exclude whether it's a gonococcal, non-gonococcal infection, urethritis. Now, in women, it's even more complicated because a woman will present with a vaginal discharge. The first thing you need to do in your approach to a female patient with vaginal discharge is to establish whether is it a vulvovaginitis or it's a cervicitis. What does it mean? It means, is the discharge coming through the cervical os, like here you can see in this patient. So here, if you can see, this is the cervix, the cervical os, the exocervix. So you can see that the pus is coming from the cervical os, and this exocervix, it's a little bit inflamed, so this is a cervicitis. Okay, so all you do is you try to remove excess with a swab, to try to remove excess pus. You place a speculum. You will then see whether there is a discharge coming through the cervical os or it's coming from the vaginal. Like in this case, you can see that the cervical os is clean, but actually the pus is here throughout the vagina. So this is a case of vulvovaginitis. Now, it is very important to make the difference between vaginitis and cervicitis because the approach to the treatment is not the same. And the reason it's not the same, it's because different pathogens, the pathogen that cause cervicitis are completely different from the pathogen that cause vaginitis, okay? The pathogen that cause vaginitis, we have 3 common pathogens that cause vaginitis. We have bacterial vaginosis and Candida albicans. That I said, those 2 are not sexually transmitted infections, but they are very highly common causes of vaginitis. And we have a 3rd one that is a true sexually transmitted infection, that is Trichomonas vaginalis. Okay, then the pathogen that causes cervicitis are completely different from the pathogen that causes vaginitis. And all pathogens that cause cervicitis in women cause also urethritis in men. So we have Neisseria gonorrhea, Chlamydia trachomatis, Mycoplasma genitalium, Ureaplasma urealyticum, and sometimes now Trichomonas vaginalis may at some point also be able to cause urethritis, okay, at some point, but it's not a commonest cause. So you have to establish that because your treatment will depend on the likely cause. Then the other thing that is very complex in women, it's whether to make the difference between vaginal discharge in a healthy woman, in a healthy person, and abnormal vaginal discharge. It does not look the same. A normal vaginal discharge is clear. It's very clear when you see the fluid, it's clear. And sometimes it might be whitish. It's whitish, but the consistency should not change, okay? It's clear or whitish, so you can see it here. Because sometimes whitish color can be a candida infection, a yeast infection, but the discharge should be clear. And the odor should not be there. It should not be a discharge that is smelling, but sometimes you can have slight odor that is not a strong smelling. It should not be smelling. Okay, and sometimes it can leave just a yellowish tint on your underwear, but otherwise it should not. It should not. Okay, and the changes in consistencies of that fluid can only occur throughout the menstrual cycle. Let's say a woman is now going through menstruation, then that's different. That's different, because there then you will have fluid maybe that is reddish, during menstruation. But abnormal vaginal discharge, you have changes in the consistency. Sometimes it becomes thick, very thick. There is a changes in consistency. It appears yellow or green or gray, so sometimes yellow or green. Usually it's suggestive of sexually transmitted infection, mainly the commonest one that causes cervicitis, like your Neisseria gonorrhea, chlamydia, or maybe the cause of vaginitis like trichomonas infections, caused by Trichomonas vaginalis. Okay. Then when it's Candida infection, it really resembles cottage cheese in color, the cottage cheese, the color of cottage cheese, and the consistency will be also the same like cheese. And the Candida is also, accompanied by accompanied by vaginal itchiness, the lot of itchiness that the woman will be scratching. Sometimes you can see lesions because she keeps on scratching without stopping. And in condition like when you have a yellowish or greenish discharge, usually it looks foamy or frothy, and especially in patients with infection due to Trichomonas vaginalis. And it has a very strong smell. We call it a smell of fish. And especially what we identify, you just take the fluid, you put on a slide, on a glass slide, you add 10% of hydroxide of potassium, and it will develop a very strong smell that we call a fishy, a smell of fish, or a fishy smell, especially in patients with Trichomonas vaginalis infection. So, and sometimes it's brown or blood stained. So those are different things that you should look for. So this gives you a summary, because in women, it's a very complex situation. So when you see a female who present when you do the clinical examination of a woman with vaginal discharge, you try to look, two things. You try to look at the color and the consistency of the discharge, and also the smell, okay? Especially if it's white colored discharge, okay? Like a cottage cheese, that's one thing. And usually when you have a strip of pH, you test, you check for the pH, is 4.5 or below, you can suspect Candida infection. And especially the woman will complain with vaginal itching or soreness, okay? And sometimes when she's having sexual intercourse, it's very painful, or you can see the erythema, even on the labia and on the vaginal canal, you will see the erythema, or you will see some fissures, or maybe sometimes because she's scratching there, you can also see some lesions. Okay, so often we don't collect a specimen for the lab unless it's a recurrent candidiasis. And we will speak about recurrent candidiasis in one of the next lectures. But then if the pH is above 4.5, then it's better that you collect a specimen. You need to collect a high vaginal swab, and you collect also endocervical swab that you will send. The high vaginal swab, we will check for bacterial vaginosis, we check for Trichomonas vaginalis, and the endocervical swab, we check for Neisseria gonorrhea and chlamydia trachomatis. So we check for that. But if you really you have a pH above 4.5 and you have a fishy or offensive odor, or maybe when you do the 10% KOH test, you develop there is that fishy odor that comes in. Okay, you then check the consistency and the color. If it's thin, white or gray, homogeneous, discharge, you can already suspect the bacterial vaginosis. But if the pH is high, but you have a yellow, green, frothy or foamy discharge, you can suspect trichomonas. Trichomoniasis or infection due to Trichomonas vaginalis. But in all those cases, collect endocervical swab. You can use a PropTech swab for endocervical specimen, and you can use maybe Dacron swab or any other swab for high vaginal swabs that we will look for the causes of vaginitis. And when we look for that, sometimes it can also be infection due to herpes. It can also be herpes infections. Then the second group of STIs are what we call STIs that cause ulcerative diseases. You can see here genital ulcers. You can see the ulcer here. And this is in a female patient. You can see here. So all those ulcers are caused by different things. And here you can see a typical classic vesicles in a patient with a herpes simplex virus type 2, typical vesicle lesions at the beginning. You have those vesicles, but if the patient spends some few days, all those vesicles will be ruptured and coalesce into lesion that can come like this, but it will be painful lesions. Okay, then you have here infections that's what we call genital wart. It's caused by human papillomavirus, and this one you have genital ulcer with with painful inguinal lesions that you can see, inflamed lesion that we call BIBOs. So it can be either be lymphogranuloma venereum, but sometimes also infection due to Haemophilus ducrei can also give you that. But for Haemophilus ducrei, it's really painful. Okay, but for LGV, it's not. And in LGV, you will have multiple ganglion, swollen ganglion. And for Haemophilus ducrei, it's usually one isolated inguinal ganglion, and that contains pus in. So among the commonest causes of sexually transmitted disease that cause ulcerative disease, we have Treponema pallidum that causes syphilis. We have Haemophilus ducrei that causes chancroid. We have herpes simplex virus that causes herpes. We have chlamydia trachomatis that causes lymphogranuloma venereum. We have Calymatobacterium that we also call Klebsiella granulomatis. Okay, that cause a condition called donovanosis. So others, those that can be able to cause also extragenital sexually transmitted diseases that you can find those in other parts of the body. Like here we have a patient with secondary syphilis. You can see rash all over the body at the back. This is a patient with a secondary syphilis. You can also see here another one in the hand. This is a case of secondary syphilis. Okay. You can also see a lesion here. This is also a case of, this is also a syphilitic chancre that you can see there. It's different from this patient who have a herpes, oral herpes. This can be either due to HSV1 or 2, because HSV1, it's mainly through kissing, but HSV2, it's through genital intercourse. So this is oral herpes. Then here you have cases of disseminated gonococcal infection, gonorrhea infection outside the genital area. Like here you have a genital infection here and here. You have arthritis, swollen fingers. It's an arthritis due to a gonococcal infection. And sometimes gonococcal infection can also give you pharyngitis or tonsillitis, you know. So you need to be careful if you have pharyngitis. You also need to try to explore patient sexual behavior, you know, if it's not a sexually transmitted infection. Now, what is the therapeutic approach to STI? Remember, this lecture was just an overview. Before that, we start, you know, getting into details with those individual sexually transmitted infection. The therapeutic approach, there are two approaches to treatment. We have what we call etiologic management versus syndromic management. The etiologic management, it's actually by trying to do the test, laboratory test, so collect specimens, send to the lab, diagnose, give a specific etiology, and they treat according to the cause. That is etiologic management. But usually we will see the difference between etiologic management and syndromic management, usually in many resource-limited countries where there are poor lab infrastructure and people don't have enough money to do the test or resources. So we approach situation we're using what we call a syndromic management. So syndromic management is identification of signs and symptoms and treatment for likely causes. Like if you know a patient comes with a male patient who comes with urethral discharge, you know that the commonest causes can be Neisseria gonorrhea and chlamydia trachomatis. So the first treatment you start is something that will cover those commonest two pathogens. But then there are possibilities where you might, you know, undertreat that patient. Maybe you missed an etiology that you did not think of, okay? So those are problems with syndromic management. Or if you know that this patient comes with an ulcer, what are the likely causes of ulcer? Then you select an antibiotic depending on the likely pathogen. That is a syndromic approach. So there are those approaches, syndromic or etiological approaches, have their advantages and disadvantages. Now, the advantages of a syndromic management is that you see a patient, you see his or her clinical presentation based on the syndrome she or he is presenting with. You can immediately start the treatment on the basis of the likely pathogen, okay? And that approach is cheaper, so low cost, you know, it's easy to implement, and it's widely done in a low or in a resource constrained countries, in countries where there are no laboratory infrastructures, or maybe we have so many patients, it's very difficult to start testing them, because if you collect a specimen, you call the patient to come tomorrow for the result, that patient might not even have money for the transport to come back. So in the same time, in the meantime, the patient will go back and keep on transmitting the infection. So those are the advantages, but the disadvantage is that the treatment depends on the epidemiologic surveys of the likely causes. But how often do countries in resource-limited settings, they actually do regular surveys to know the likely pathogen, the likely treatments that, you know, that are able to cover those pathogens, susceptibility pattern of those different pathogens, so that you are able to select a correct antibiotic. You know, so that's the problem. So, and by giving also antibiotics blindly, there is a possibility of resistance development due to the overtreatment, because you pump those patients with all antibiotics to try to cover blindly any pathogens. Okay, so you can also experience treatment failure due to undertreatment, because sometimes, remember I say that Urethritis can be caused by chlamydia, Neisseria gonorrhea, and sometimes Trichomonas vaginalis can also be a cause. So, but usually what we do in men, we give a third generation cephalosporin like ceftriaxone or fourth generation cephalosporin tablet for Neisseria gonorrhea. Then we put the patient on doxycycline or a macrolide to try to cover chlamydia infection. We don't give any cover for Trichomonas vaginalis. Maybe it might be the cause, so you can undertreat that patient. But in women, usually where we know Trichomonas vaginalis infection is common, we also add the metronidazole to try to cover that. And you might be, but if you don't suspect candidiasis, you might not give any antifungal cover. So you might undertreat the patient. The patient might come back, you know. So those are challenges associated with syndromic management, but otherwise, they are very practical in a resource constraint setting. They are cheap, and you can start the treatment immediately to try to reduce the rate of transmission. But in many developed countries, first world countries, we use what we call etiologic management. Etiologic management where the patient arrives, the patient will wait there, you collect a specimen, you go to the lab immediately, you have the answer. You know the pathogen, you know whether what antibiotic to use. So you treat the exact cause, and you have a knowledge of the antibiotic susceptibility patterns. But of course, the disadvantage is that there are areas with diagnostic challenges in some settings, you know, as I said, and it's an approach that is very expensive. If you have to test every single patient, it's not easy, okay? So this was our first lecture. That is an overview on sexually transmitted infections. And now follow our subsequent lectures, where we are now going to give details of every single of you know, those conditions that we discussed now. Thank you and goodbye.